Hello, before I get started, just want to let y'all know this is the last chapter that's going to be covered on your midterm exam, which will be next week. Okay, so please be on the lookout for an email from me. I'm going to have all the instructions for your midterm. Don't miss that. This week, we're going to continue talking about PPSs, but we're going to go over outpatient PPSs. Because since the inpatient PPS system was so successful, the Department of Health and Human Services, DHHS, and CMS decided, okay, we should use PPSs across the continuum of care, meaning for all types of healthcare settings, like the things listed here. All right, so we're going to go through each of these. The Outpatient Prospective Payment System, OPPS, was implemented in the year 2000. And just like the IPPS for inpatient services, these payments are based on fixed rates, and it's predetermined and paid under Medicare Part B. Okay, this is for services at hospital-based clinics, emergency department visits, observation, and ambulatory surgery departments. Which is the same as outpatient surgery. Okay, the patient can leave the same day that they have their procedure. And again, the goal of this was to incentivize hospitals to treat patients more cost effectively so that Medicare doesn't take the hit if a hospital is overusing resources on a patient. The hospital takes the financial risk. They have to pay if they overuse, okay? CMS has an inpatient-only list, which has all of the services that Medicare will only pay for if they're done on an inpatient basis because of how complex they are. If a service is not on this list, in order for it to be paid for on an outpatient basis, then it has to meet the reasonable and necessary rule. It has to basically meet this set of requirements that show it's not as complex as the norm. Okay, if you remember from last week, IPPS uses the DRG grouping system. For OPPSs, now CMS created the ambulatory payment classifications, or APCs, to reimburse for outpatient services. It works very similarly. All outpatient services that are covered are going to be assigned to an APC group. And so all of the procedures in each group are going to be similar. They use similar amounts of resources, etc. Okay, the payment is prospective, meaning it is set beforehand, and it is fixed, and it's updated every year. Okay, each year they'll look at all of them and make adjustments if they need to. All of the services in an APC have to meet the 2 times rule, which says that the median cost, okay, which median does not mean average. Median would be like the middle cost. If you list out all the costs from smallest to largest, okay, it would be the number in the middle. So the 2 times rule says the median cost of the most expensive item or service in the APC group cannot be more than 2 times greater than the median cost of the least expensive item or service in that same group. And this is just so that there's not, 2 different procedures in the same group that are very different in cost. They want everything in one group to be relatively close to the same amounts. I'm just making up these numbers. This group is for services that cost $1 to $20. The next group is $21 to $40, and so on, right? You wouldn't want something that costs $1 and something that costs $100 in the same group, okay? All right. Procedures are identified by the Healthcare Common Procedure Coding System, or HCPCS. HCPCS has 2 medical code sets. Level 1 is the current procedural terminology, or CPT code set. This one's for all procedures and services done by physicians, non-physician practitioners, hospitals, labs, and outpatient facilities. This code set is maintained by the American Medical Association, or AMA, so they're the ones that look at it and make updates to the code set each year. CPT codes have 5 numbers, and in the book they're arranged by body system. HCPCS Level 2 codes is a code set used by providers and medical equipment suppliers when they file claims for any supplies, medications, transportation services, and any other items or services. So Level 2 is maintained by CMS. It also has 5 characters, but this one is a letter followed by 4 numbers. And I know we've also talked about ICD-10 CM codes, which is the diagnosis code. Now we're adding HCPCS Level 1 and 2 codes. So you do need to know the difference between these. And I think the easiest way to look at it, ICD-10 CM is why the provider did or used something, right? The why is because this patient has this problem, and so that's what the diagnosis code is, right? HCPCS Level 1 or CPT is what the provider did, what procedure, what service. And then HCPCS Level 2 is what the provider used, what medications, what equipment, things like that. Okay, so pause this video, go back and make a note of this so you can understand it now. All right, so for a provider to get reimbursed for an outpatient medical service, the coder has to code an ICD-10 CM code showing what the patient's diagnosis is to prove that medical necessity, right? Then we have the CPT code saying what procedure was done, and the HCPCS Level 2 code saying what medications the patient received, if any. Even though we have the ICD-10 CM code on there, it's the HCPCS codes that determine the APC payment. Okay, so the ICD-10 code is not swaying payment for outpatient APC payments, right? It's the HCPCS codes. But we need the ICD-10 codes for that medical necessity, right? What's the reason they used all this equipment, or what's the reason they did this procedure? Okay. The payment rate and the co-payment that are calculated for an APC apply to each service in the APC group. So if multiple procedures are done in the same operative session at the same time, the most expensive APC group is paid in full, and all the other groups are paid at half their APC rate. The biggest difference between like a fee-for-service payment system and a PPS payment system is that in a PPS, you can package and bundle some secondary services into one payment with the primary procedure. With fee-for-service, everything is basically built separately, right? So packaging is when minor ancillary services that go with the procedure are combined into one payment. For example, if someone gets an MRI done, then the contrast or the dye that's used during the MRI is packaged into the total payment with the MRI. Packaging is only used in the OPPS, okay? Bundling is when a set of predetermined services that are done together are combined into one payment. So say you're having neck and back pain, right? Your doctor's going to order an MRI for the cervical, thoracic, and lumbar regions of your back. When those, or if and when those 3 tests are done in the same encounter, then they're bundled into one payment, okay? Status indicators are assigned by CMS to HCPCS codes to identify if a payment is made separately or as a packaged payment. So if a service with one of these status indicators is performed, all of the ancillary things that happen with that service are packaged into one big payment with the service, okay? I put a few examples of some of the status indicators at the bottom of the slide. There are a lot more than these 4 though, and some of them, like an in status indicator says 0 payment. So they all cover different topics. You don't need to memorize these, but if you can, definitely go check these out to give you a better idea. All right. An outpatient encounter includes all outpatient procedures and services that one patient has on the same day. If someone has multiple procedures and receives like multiple services on the same day, they can be assigned to one or more APCs. Each APC is weighted and has a set prospective payment amount, a lot like how DRGs are weighted and have a set amount. If a patient is assigned multiple APCs, the payment amounts are added together to reimburse the hospital. Okay, weights are based on the average resources used to treat a patient in an APC. And this is going to sound very familiar. We talked a lot about relative weights already. A weight of 1.000 being the average. So if a relative weight, or if a weight is higher than 1.000, that means more resources were used to treat the patient. So the payment is going to be higher. Okay, if it is below that number, 1.000, then less resources were used, so the payment will be lower. Okay. Then CMS applies a conversion factor based on the hospital's annual outpatient quality report. They can also apply discounts, like if a bilateral procedure is done, a procedure on both sides, they're not going to be paid the complete full amount, as if they were to have to go in, separately, this side and this side. Okay. Then we have the wage index to account for cost of living. I mentioned that a few times. It's cheaper to do most things in Louisiana than California. Okay, so that takes that into consideration. And then add-ons such as pass-through payments to give the hospital more reimbursement if they use innovative biologicals, drugs, or technology. Okay. An ambulatory surgical center, or ASC, only does outpatient surgeries for patients that don't need to be hospitalized. So they'll come in, do the procedure, have a little bit of recovery time, and then go home, usually in much less than 24 hours. An ASC can either be independent, like an independent building, not part of a facility, or operated by a hospital. Payments for ASC is under Medicare Part B, and that uses the ASC payment system. CMS has a list of all the covered procedures in an ASC setting because there are some procedures that may require more monitoring after the fact or pose like a higher risk to the patient, so they're not included. So those would have to be done in a different setting. ASCs get a single Medicare payment for any covered procedure that includes all of the facility services, so nursing services, drugs, administrative, housekeeping, etc., and also services like blood supplies, supplies for administering anesthesia, radiology services, etc. These payment amounts are predetermined, right? And the ASC is reimbursed 80% after adjustment for regional variations, aka cost of living. And so then the patient's coinsurance is that remaining 20%. That's what they would owe. Outpatient code editors, or OCEs, are software programs that Medicare administrative contractors use to basically audit coding data. Remember, MACs, Medicare administrative contractors, MACs are those private companies who process Medicare claims. Okay, the software uses a set of logical rules. Remember, we talked about logic and knowledge-based software a few chapters ago. So the logic rule helps it to see if the codes are correct and if they're appropriate for what's documented, for what services were done. OCEs have 4 basic functions. One, to edit the data on the claim for accuracy, to specify the action the MAC should take if they find an edit, to assign APCs to the claim for hospital outpatient services, and to determine payment-related conditions that require a direct reference to HCPCS codes on modifiers. So when the software finds an error, it will edit the claim. The edit can be for just one line item or the entire claim. And the goal here is obviously to weed out incomplete or incorrect claims, try to detect fraud and abuse, and then to encourage correct coding practices. When there is an OCE edit, the claim can either be rejected, all right, and then, and same thing here, either one line or a few lines can be rejected, or the whole claim is rejected. And at that point, then the provider can try to correct and resubmit the claim. Okay, they can't appeal the decision here, but they can try to resubmit it. And then the claim could also be denied. So for this, they cannot resubmit the claim, but they can appeal the decision, or the claim can be placed on suspension, which means the payment is delayed until they get more information. So facilities need to monitor all these things because, if the same thing is getting rejected or denied over and over, then it could just be that the coders need better training on that specific thing. Okay. Skilled nursing facilities, or SNFs, provide short-term skilled nursing care and rehab to Medicare patients right after at least a 3-day hospitalization, okay, an acute care hospitalization, right? They can receive up to 100 days of SNF-covered services and are responsible usually for a portion of those services. Not all residents in a nursing home are considered skilled. Skilled patients require like a little more attention, okay, more nursing care, okay? Until the late 90s, nursing homes were reimbursed by a retrospective system that was cost-based. So it depended on routine, ancillary, and capital costs. Then in 1997, the Balanced Budget Act mandated that skilled nursing facilities, the Skilled Nursing Facility Prospective Payment System, so SNF PPS. This pays a daily rate and still takes those three components into account, right? The routine, ancillary, and capital costs, and includes also rehab services. The prospective rate is based on a case mix system with reimbursement calculated by measuring the type and intensity of the care and also how many resources are used. So the measure is based on the RUG classification system, which stands for Resource Utilization Groups. So the name kind of tells you what it is, right? Resource utilization groups. The groups are going to be based on how many resources are utilized. So similar resources are going to be placed together. There are 7 major classifications that I'll talk about next, and then 44 categories within those 7. A resident cannot be placed in more than one classification. They place patients into these groups based on information in the minimum data set, or MDS. The MDS is a clinical assessment of the residents' functional capabilities and their health needs. So they do this assessment on every patient when they're admitted, if there's like a major change in their status, and then when they're discharged. Okay, here's the 7 major RUG categories: rehabilitation, extensive services, special care, clinically complex, impaired cognition, behavior only, and decreased physical function. Each RUG has its own nursing and therapy weights that are applied to the base rate. So just like how relative weights are used, the payment that the SNF receives is a combo of the base rate and the resident's RUG score. And like others, the base rate is adjusted for local geographic variations in wages, right, cost of living, and for the patient case mix index of the facility. The case mix accounts for the differences between residents, okay? Residents that use similar amounts of resources are grouped together, right? All right, moving on. Home health agencies provide that same skilled care we just talked about, but in the patient's home. So a doctor does have to order this, and it's for patients that can't physically go to the doctor's office for their treatment or care. The home health prospective payment system was implemented in 2000 to cover home health for Medicare Part A and Part B beneficiaries. The only cost the patient has to pay is 20% of durable medical equipment, so wheelchairs and walkers, etc. They can have an endless amount of 30-day-long episodes as long as they continue to meet the criteria. So they're recertified every 30 days. The certification can be done by either a home health doctor, a non-physician practitioner that works with the certifying doctor, or a doctor that cared for the patient while they were hospitalized. Okay, they can order home health to go in once the patient is discharged. And the last bullet there, obviously they have to document everything to make sure they're giving quality care and to support, the medical necessity for reimbursement purposes. Okay, home health agencies use the Outcome and Assessment Information Set, or OASIS, to do their patient assessments. Patients are classified into home health resource groups, or HHRGs, which are case mix groups that group patients by similar conditions and how many resources that they use. In January of 2020, a new home health PPS case mix methodology was implemented. It's called the Patient-Driven Groupings Model, PDGM. So this focuses more on clinical characteristics, so the payments match what the patient's needs were better, okay? Whatever the patient's principal diagnosis code is, puts them in a clinical group that explains the main reason, right? The primary reason the patient needs home health services. So an example of that would be, if a patient has a primary diagnosis or principal diagnosis of stage 2 pressure ulcer on the left heel, they would be assigned to the wound clinical group because the main reason for home health care would be wound care, okay? Okay, the PDGM uses the same 3 domains of the home health resource group: clinical, functional, and service utilization. So very similar to that. And here you can see the structure of the patient-driven groupings model with each of the functions. If this is hard for you to see, I just pulled this graphic from your ebook, so you can check it out there as well. The first step classifies each 30-day period into either community or institutional admission type, depending on what healthcare setting they were in before home health. The first 30 days are early, all other 30-day periods are late. The second step groups each 30-day period into one of 12 clinical groups based on their principal diagnosis, right? Like I just gave you the wound example. Those are all the other clinical groups there. The next one designates functional impairment level for each 30-day period. So this is based on that OASIS assessment I mentioned. And then the last step is a comorbidity adjustment based on the patient's secondary diagnoses. So it goes through all of that, and then we get the home health resource group, or HHRG, for that patient. Okay, that's all I have for you today, and good luck. See you next week.